Welcome to the Appalachian Wellness Connection. Join myself, Dr. Kevin Britt, and my good friend Dr. Micheal Bryan as we guide you through natural solutions for better health and lasting wellness. From chiropractic care to functional healing, we're connecting you to the best in holistic health from the heart of East Tennessee.
Hey everybody, in today's episode, we're going to be talking to that person who has chronic back pain or sciatic pain. We're breaking down what spinal decompression is, how it works, who it helps, and why it's one of the most effective non-surgical treatments available today. We will be separating fact from fiction, answering some of the most common questions about treatment, and sharing a real-life success story.
So the most important, not most important, but one of the most important things is why are we going to be focusing on spinal decompression? It doesn't seem like it would be a very exciting subject, but really it's a gigantic problem in society today. A lot of people struggle with low back pain. Globally, it's estimated that 619 million people were affected by low back pain in 2020, and that number is projected to go up by 2050 to 843 millions, with an estimated 80% of adults experiencing some form of low back pain or back pain at any point during their lives. Actually, there was a study in May 2015, and they went over some of the statistics, but one thing they really pointed out and was a big problem is that low back pain is the second leading cause of disability worldwide, and it's estimated that 1% of the world's population is disabled from low back pain. So they don't just experience low back pain; they're on disability from low back pain. And so our commitment to helping these people and doing it as holistically as possible, one of the ways is with spinal decompression, because it's one of the more cutting edge treatments that we use, even though it's so simple, but it's so powerful in how it works. And so we've invested a lot of time and energy in this technology because of a lot of the scientific research that has gone into it, and we'll get into that in just a little bit. But first we want to understand what exactly is spinal decompression.
So spinal decompression is a non-surgical option. I think that's important to look at, because oftentimes when we hear I had decompression, sometimes that means a surgical decompression. So the greater context around what we're talking about is non-surgical spinal decompression. So to break that down, the ultimate goal is to relieve pressure in the disc. A decompression table is a specialized table that gives a gentle pull or stretch in a passive way to decompress the disc, essentially create a vacuum into the disc, and that vacuum is going to almost how like a vacuum brings dirt and lifts it up toward the collection point. Decompression of the disc brings the herniated or the part of the disc that's shoved out to the side, it brings it back into the midline. So it creates a vacuum to bring it back in its proper place. Oftentimes we hear, how is spinal decompression different to traction? Well, in our office, it's quite a bit different. Generally, traction is more one-dimensional. It is a basic table. They hook a cable up to you, straps you around a cable and a harness, essentially, and it just pulls in one direction. It's usually measured by weight. So say the person weighs 150 pounds, they're going to pull some percentage of that 150 pounds. Let's say 40% one day, 45, and then 50, but it's just in that one motion. And where some people can really benefit from that, a lot of stubborn disc issues actually require more specific types of treatment. And so in our office, we use a machine that actually can laterally flex and laterally bend the patient to the left and the right. And we have around 20 different protocols that we can specifically utilize based on what type of disc issue, how bad is it, what side is that disc issue on. So it's more of a three-dimensional approach. And I think that that is what leads to our higher success rate ultimately when we look at how we do things versus the traditional, traction type model, if that makes sense.
Yeah. So, like as Dr. Mike was just saying, it creates the scientific term for it is a negative intradiscal pressure, but you can just think about it. It's pulling the bulging or the herniated disc materials back into place. Now that's just one aspect of what spinal decompression can do to help relieve pressure from those compressed nerves and discs. But it also can bring in, nutrients and oxygen into the damaged areas, which is obviously going to accelerate healing, because that's one of the main reasons we see degeneration in the discs is because it's lost the proper nutrition. And that's because one of the main reasons is because discs are very unique in our body. They don't have an ample blood flow. We used to think that they didn't even have any nerve innervation, which we'll get into the science of how that's not true anymore. We know that. But so that's just one way that it works. Another way is when we're looking at the nervous system. When you're decompressing the disc and you're pulling that discal material back in, it's physically taking that material off the nerves or the nerve roots, which are coming off of the spinal cord. And most commonly in the low back, they're going all the way down your leg. And when those nerve roots are being compressed, that's how you get sciatic pain. You can't have sciatic pain without a nerve root being compressed, and that's one of the things that spinal decompression really helps with, is that sciatic pain. But also it helps with just overall and general low back pain. And we can get into a couple studies of how it actually does that. The first main one is it's a study called The Tissue Origin of Low Back Pain and Sciatica. This was actually done in 1991. So we've known this for quite a while. It comes out of the journal Orthopedic Clinics of North America. They took 700 spine operations and they only used local anesthesia. So the patient could actually communicate with the doctors while they were doing this. And so what they did was they were looking to figure out exactly what tissues were causing the pain. And so they essentially, you can think of it like this: they attach strings to different tissues and they would just pull on them and say, how does that feel? Do you feel any pain there? Do you feel any changes there? And one of the things we learn or we hear a lot is that a lot of low back pain comes from the facet joint capsule. And according to this study, that's actually pretty rare. What this study showed is that the most common area of low back pain is the annulus fibrosus, which is the outer ring of the disc. And for a very, very long time, and we thought that the annulus fibrosus was kind of just an inert tissue. It's just like it doesn't change. It just gets injured and you can't really heal it that well. But what we know now is that you can heal it for a couple of different reasons, even though there's not a lot of blood flow, which is the primary way that we bring those healing proteins and oxygen and everything in there to heal it. We can heal it through motion. And that's really what makes the disc unique, is that it's not direct blood flow that helps heal that tissue, but it's motion. And one of the most common things we see in people with low back pain is a lack of motion, right? It doesn't matter. A lot of people say, sitting is the new smoking, and we do see that. And when you sit for long periods, you're not getting motion in that lumbar disc. You're not getting motion in a lot of places, but that affects the disc more directly because you're not getting that influx of, like I said, oxygen and proteins and all the other building blocks to help heal that disc. And so that prolonged sitting, or it could even be positions where you're prolonged standing, prolonged laying down, it's just a lack of motion is what causes the disc to not heal, and ultimately that lack of motion leads to degeneration. So when we are taking care of somebody with low back pain, chronic low back pain, or sciatic, The general approach is the same, and it's to get motion back in that area. One way we do that is with spinal decompression. Another way we do that is with the chiropractic adjustment. And that is really what we see from this study, is that that area is the most common source of low back pain, even though we were actually taught sometimes, and most people don't realize that that's not where it comes from. That's not where pain is not coming directly from those other tissues like the muscles. A lot of people think it's just a muscle issue, but chronic low back pain lasts so much longer than just a strained muscle would.
Yeah, so you remember when we were in Orlando at that shockwave seminar, we were going through a study, and in the study, what they were looking at Bold's disc, and what was interesting, it was a rat study, but what was interesting is how they caused the disc herniation to begin with. What they've done in the rats is they surgically fused essentially the two vertebrae to create a lack of motion, and just the lack of motion over time, they knew that would result in a herniated disc. And so just to kind of clarify what Dr. Kevin's talking about, these are things that scientists do every single day when they're designing these experiments where they have to take a rat and they have to make that herniated disc. This is not a foreign concept. This is something that they've known for a really long time. When we look at that study, what year was that study? 91?
1991.
Yeah, so, we look at, a couple decades ago, this is not new information by no means. I think, one of the things that I want to talk about in the other study that we were talking about is the disc is really interesting when we look at that annulus fibrosis, and we look at how that was the most common site of pain. When they looked at the 700 different people, the annulus was by far the most common area of pain. And what they started noticing is it is a mechanical / chemical event most of the time. And so if we visualize a sponge, imagine we have this sponge, and that sponge is full of toxins, it's full of waste, it's full of acid, it can be full of whatever you want at the end of the day. We know that we better get that acid out of that sponge, and the way that we do that is we just squeeze it. We apply mechanical pressure. That acid is going to then leak out, clean out, and then we let it go, clean water comes back in. So when we look at this mechanical movement of spinal decompression, and we look at that analogy of the sponge, we can see how that chemical event and mechanical event can alleviate so much back pain, and how it can actually allow for the body to regenerate and heal. If you imagine, if that disc is full of toxins year in, year out, you're going to be accelerating the breakdown process. And that accelerating, when you accelerate that breakdown process, of course you're going to lead to more and more dysfunction, more and more pain. And so we want to stop that in its place and start regenerating that tissues as fast as possible. Now, one of the things that we're going to talk about next is some of the conditions that we see with spinal decompression. And so to understand some of these things, let's look at another analogy here. Imagine you had a Coke can and you stepped on that can and smashed it. When we look at that smashed can, what we see is in that smashing process, it got thinner in height, the height reduced, but oftentimes the width actually expanded out. So if we contrast that to degeneration of the spine, we can see how that disc will start to push out and start to become more lateral, and that actually leads to the herniations, the bulging of the disc. And so when we look at spinal decompression, chronic low back pain, and even chronic neck pain, because we can do spinal decompression in the neck, we traditionally talk more about the low back because that's done a lot more common than the neck. But either way, you can do both. So with chronic low back pain, this issue is more local to the disc. Then when we look at more that sciatic nerve pain or radiating radicular pain, that's going to be that degenerative process starts to push that disc out more and more and more, and that disc is starting to put pressure on the nerve. And so when we look at that vacuum effect, we can see how moving that disc out of the way is really going to help the sciatic pain or the radiating pain. But then we look at the local disc when we mechanically traction and open up and go back to the analogy of the sponge, we can see how that can affect chronic low back pain. So it's the same therapy, but it's going to be slightly different mechanisms of actions based on some of the conditions that we would treat. So herniated bulging disc, degenerative joint disease, sciatic and nerve pain that travels, spinal stenosis. This is more of like a just straight up degenerative process to open that up, getting those discs healthier and healthier and healthier. We talked about the chronic low back pain. And here's an interesting one that we don't always think about is post-surgical pain, or even someone had a disc herniation, they elected for a microdiscectomy, which is basically the medical approach is they're just going to kind of try to shave out that herniated aspect that was putting pressure on that nerve. They just try to cut around the bone and basically remove that disc and basically discard it. Well, that didn't solve the problem because, as Dr. Kevin alluded to earlier, it's a lack of motion that pushes that disc out to begin with. So if we don't address that, the likelihood of that herniation reoccurring is actually quite high. I mean, I've seen this in practice, and Dr. Kevin has too. We've seen patients that are really young, say they're 20 years old, 25, go in and have one of these microdiscectomies, and they come in 35 or 40, and they get the same issue again. And so instead of doing the same treatment, we're going to decompress that disc and try to bring that in and solve the problem and fix it at its source, as opposed to just trying to clip it off and solve the symptom, but rather we're just, ignoring the cause, if that makes sense.
Yeah. And, a lot of times people come in and they don't think they need decompression, or we actually have a lot of people come in and say, I want spinal decompression. And we still need to figure out if that's even a good idea for them, because it's not for everybody. Not everybody needs spinal decompression. As Dr. Mike said, anyone who has been diagnosed with any of those herniated discs or degenerative disc disease, sciatic pain, typically they're going to be great candidates for it. But that's why when they come in, we have to do our due diligence. We have to do a good exam and take x-rays and see exactly what's going on, to see if spinal decompression would be good for you. There are a few people who it doesn't work for. Obviously, people with spinal fractures, it's not a good idea. Some people with post-surgical, as Dr. Mike was just saying, it's great for some people with post-surgical pain, but it depends on what surgery they did. If they have spinal fusion, it's not a good idea. And then another one is infections, because if we start moving things around when there's a localized infection, those infections can theoretically spread. And so we definitely don't want to do that. So we have to do our due diligence before we can just throw someone on the decompression table.
And I think one thing too to mention when we're talking about these back surgery, post-surgical treatment, a lot of that's the timing factor too. It's not that some of these patients can never do spinal decompression, but if they're, not that far out, probably not good practice to try to do that too soon. Even with maybe like a hip replacement, we're working mainly on the low back, but we can easily see how let's let the body heal and recover before we start adding more things. So sometimes it's more of a timing issue as well. And so if we look at what to expect during, a spinal decompression session, very, very simple. And so this is a passive process. So it's mainly just sitting in a chair on a table, and the machine's going to basically do all the work. We have to have this as a passive part of the process, because if we contract the muscles, we're limited in how much of that negative discal pressure we can achieve, because the muscles are going to inhibit the ability for that vacuum or that negative discal pressure to happen. Oftentimes, when we look at sessions on the lower end, if someone doesn't have a lot going on, maybe 12 is something that we would recommend. More on the higher end, maybe upwards of 30 sessions in a full treatment plan. I would say that for so many people, this number is so true. It's almost like a magical number. It literally happens that often, is around visit 12. So there's something significant that happens for most people around that visit 12. And that's because if you look at the law of timing, most conditions are going to start to do better somewhere between that 4 and 6 week mark. And that's where most people are around that 12 visit mark. I want to share a quick story. This was yesterday. I was doing a re-exam on, we'll call the guy Pastor. He's an awesome guy, really humble man. Come in about a month ago. It was actually at his 12th visit yesterday. He couldn't sleep. He could barely walk. It was really affecting his mood. I mean, this was affecting this man's quality of life quite substantially. And we sat down to do the re-eval, and we noticed that everything was looking good on the technology that we were tracking, and had a good visit. And then when he left, he actually came to the front desk where we happened to be, looked us in the eye, and said, "You guys were a godsend. I couldn't sleep. I'm sleeping like a baby. From the bottom of my heart, I am so thankful for the work that you do here," and recognized the importance of that work, because you're talking about a person who temporarily lost a significant amount of quality of life. I mean, when all you can do is sit around, you can't walk, can't move, can't do yard work and things like that. I mean, that takes a toll on you. I mean, the pain is, he was having was ridiculous. So just kind of a really cool story there. Made us feel good because you can't fake, you can't act the way that guy did. I mean, the sincerity, the look in his eyes, that he generally meant that his life was changed 100% just in those 12 visits. And now he's got further to go. A lot of times 12 visits is not enough to really fix the problem, but that's where you really start seeing the fruit of your labor. And we see that all the time. So some complementary treatments when we look for quicker healing. Dr. Kevin talked about the chiropractic adjustment, and that's so true. Oftentimes, that lack of motion is what starts this process. So chiropractic is a great preventative option altogether. And that's why, we preach this message of getting your kids under care, whole families under care for that preventative aspect. An ounce of prevention's worth a pound of cure, and that's so true. We can look at laser therapy, and we're going to talk a little bit more about this later on. Laser is really anti-inflammatory, and when we talk about that chemical, that mechanical chemical process, the laser does a really good job of impacting that chemical process. Spinal decompression plays a role in neuropathy plans oftentimes too, because the nerves of the back do make their way to the feet, and so if there's traffic in that lower back, oftentimes that's going to accelerate that peripheral neuropathy that the person's experienced, whether it's diabetes or whether it's chemotherapy, or even a big one that we're seeing more and more is statin drugs. There's a side effect of statin drugs oftentimes leading to neuropathy as well. And then even, functional medicine, getting chronic inflammation under control. Inflammation is a touchy subject. We equate that to a fire in your house. If you got a fireplace, you want it to be, big enough that it's providing warmth, but you don't want it out of control that it burns the house down. So a lot of people have, they're immunocompromised, they got autoimmune disease, and so that's going to limit, their recovery because they got inflammatory, challenges with how they modulate that inflammation. So functional medicine and getting that under control oftentimes is a great thing to do as well.
Yeah, so I wanted to, we're skeptics. We always try to, break down any new information we get and see the pros, the cons, and try to figure out what's going on. So I wanted to go in and I've tried to search for some common skeptical views of spinal decompression, some myths, if you will. And so we pretty much hit on them, but some people would still be listening to this and say, well, I heard this. And so one of them is that spinal decompression is just like glorified traction, and we already went over that. We are doing more than just tractioning the spine. We're adding movement into it, especially with that lateral bending motion that the tables that we use do, which adds another dimension to it. But those two dimensions added together compound the improvements that we see for people. So it's not just glorified traction, and it's more focused on the low back or in the neck. We actually have some cervical decompression too, but when people think of traction, they think of those inversion tables or something like that, and those are great in and of themselves for certain aspects. But when we have a truly degenerated disc or we have severe sciatic, it's often not enough, and it's not focused enough on what we're doing. So it's way more than just glorified traction. Another one is you'll have to do it forever. That's something that we hear with everything, and it's absolutely false. Most people are done with their treatment plan, and they can maintain the results. With some people decide to do occasional maintenance spinal decompressions, or through our care with these people, some people just continue with chiropractic adjustments. That's all they need. Some people decide to, while we're going through someone's care plan, we're also including quite a few specific exercises, whether it's stretches or strengthening exercises or really just movement exercises that helps people maintain those changes. So you don't have to do spinal decompression forever. You just have to take care of yourself forever if you want to be healthy. It's pretty simple. Some people say it doesn't actually work. I don't know why that's still being said out there. We have the scientific studies, and we have the years and years of clinical proof and examples. We can, probably have hundreds of people in this office that will sit down and talk to you about how it's done so well for them. And some people say spinal decompression would be painful. And most people will feel relief or relaxation during the treatment. If there is any pain, that's usually a red flag that there is something else going on. And so we need to change our approach to that, and we will do that. And that's why we always ask for feedback from our patients while we're working for them, but that is very rare, and it does not last long. Once we make the adjustments that we need to, or the alterations to the person's care plan, they can hop right back on there, and they get those amazing results that everybody else who comes in gets.
Yeah, so looking at, a couple of those questions where Dr. Kevin was talking about, it being a painful process, what he's alluding to is if it's painful while we're doing it. And a lot of times, if you imagine, we've talked about and painted this picture of the disc and the spine breaking down, degenerating, things are not moving. And so when you introduce motion, when you introduce spinal decompression, there's generally a process that you're going to have to go through where you're going to be maybe a bit more sore, or you're going to go through a little bit, it's going to be slightly uncomfortable. But the reality of this situation is everything that you would do if you found yourself in that position is going to be a little bit uncomfortable. I mean, if you've got a disc issue, a disc herniation that's going down your leg, you can't do anything that's not uncomfortable. You can't even sleep at night, kind of thing. So when we do introduce something new, there's a certain aspect that you're going to have to go through. I would challenge listeners to try to find a mechanic. I bet you probably couldn't find, any mechanic that's not going to preach this preventative maintenance idea, and we're going to beat this thing like a drum. Do you have to do things forever? No. But go change your oil one time and see how long your engine's going to last, right? Talk to a mechanic. Nobody's going to recommend, that you do one maintenance, thing and don't ever do the maintenance ever again. That's just foolishness. Go try mowing your yard one time and see what happens in a month, right? And so there's always this maintenance idea in every single thing that we do. So when we look at spinal decompression, non-surgical spinal decompression, the biggest thing that we're going to contrast that against is probably surgery. And so non-surgical spinal decompression is a great first option. Why? Because there's hardly any side effects outside of somebody being just a little bit sore. But you look at the things that could go wrong with a surgery. I mean, you're talking about, we see regularly, and we had a conversation the other day with someone who had a surgery, or their kid had a surgery, got hooked on the pain meds based on the recovery because the pain from the surgery is so bad, and that ended up leading to the death of their son because of those medications and overdoses and addictions. A certain amount of surgery is going to end up in death. That's the thing that we don't talk about. The likelihood of something going wrong infection, those are real things. And when you get an infection in the spine, that's not an easy thing to treat. And so I think we've got to be careful in pursuing those type things as a first option. Now, don't hear that I don't think that that's, surgery is appropriate. I think that there's a lot of times that surgeries are appropriate. Are they appropriate as a first option? Generally, not as likely, right? And so, I would say probably 80% of patients that come in, if decompression, non-surgical spinal decompression doesn't help them, they're probably looking at surgery. And so when they can avoid that, I mean, there's no downtime. I mean, when you have a back surgery, I mean, you're talking about months. I mean, some of these people, upwards of a year if something doesn't go hardly right. So there's tons of downtime with that. And then there's also that dependency on the medications and things like that. And so I think non-surgical spinal decompression is a super appropriate thing to consider before doing surgery.
Yeah, and even if you look at the medical world, there's this a book that has all of the diagnosis codes out there, and they keep updating that book every couple of years. And I think not the current edition, but the one before, there was an actual diagnosis code for failed back surgery syndrome. So essentially, somebody had low back pain, had the surgery, it didn't fix it. Usually, it gets worse. And now there's nothing else that they can do except for maybe another surgery or two. And that recently they've changed that, and I forget what they changed it to.
Well, they're trying to change. No, they're trying to change that. They've not been successful. They call it persistent low back syndrome.
Yeah, and it's so persistent that surgery can't even fix it.
Yeah, it's like an orthopedic argument. They keep going back and forth. But I don't think they've been successful in it so far.
Yeah, so there's an actual diagnosis code that insurance companies will reimburse to surgeons or primary care called failed back surgery syndrome. So, and again, not that surgery is not warranted sometimes, but it's highly likely that it's way overdone, and we have a lot of other ways to improve people's outcomes without having to cut them open, because once you go surgical, you can't go back. And I know Dr. Mike already mentioned, we called him Pastor, but there's another one that we wanted to talk about. We can call him G. We'll call him G. And G came in to us a little while ago, and
and all these stories are literally this week. So
yeah, that's true.
That's all of these are. This is not like, man, we got to go back a year ago. It's like, this is not very hard to find patients that do really, really well with decompressions. It's almost everyone.
And so G came in, sciatic pain going down to his foot. Started working on him. Nothing changed right away, because that's often how it goes. But just a couple weeks into it, the pain left his foot, but now it was in his knee. And he said it was a couple years ago, it was in his knee for a long time, and it was really debilitating. And he was, at least to me, he expressed some concern that now that's the problem, and it's going to be the problem and stay the problem again. And we kind of expressed to him, it went down your leg, hit your knee, stayed there for a long time, was a big problem for him. Then it eventually progressed down to his foot. And it's like the fact that it's coming back up to his knee and not in his foot, it's showing that it's reversing pattern, right? It's going back the other way. And it was only in his knee for, a week or two. And then he came in, and this guy is a smart guy. He works in a very cool field. But he was very, very pleased. And he was doing both chiro and decompression and the exercises that we taught him, and he's been doing wonderful, because it's no longer in his knee, it's way higher. He comes in with a smile on his face, and he's not usually the most smiley looking guy.
Yeah, definitely not.
Yeah.
But it's interesting too, when we break down, we'll talk about this more in another episode. We want to try to keep these limited in time and things like that. But the reality of it is you can look at any A&S chart, any nerve chart, and you will find that the lumbar spine, in particular, say L5, that nerve is going to come out of the spine, innervate the hip, control part of the knee, and make its way to the foot. So it's not rocket science when we start seeing these patients that they've got these foot issues. It's going all the way down to, may not be a foot issue, but it's going all the way to the feet. and it starts migrating up to the knee, up midway through the leg, and then into the hip, those are all normal recovery patterns because that nerve goes all the way down there. And so when you're removing that pressure and that nerve is actually recovering and healing, you're going to see that it takes that place. We want to invite, if you're in the Northeast Tennessee area, and you're looking for, to try spinal decompression and see if it's right for you, schedule a consultation online in our office. Call our office, 423-299-1895. Look us up on our website, integraltn.com, social media. Give us a call, and we'll sit down and talk to you to see if spinal decompression is right for you.